Hello, and I would like to welcome everybody to our ECHO session today on pain management in palliative care that will be presented by Dr. Carmen Johnson. Before we get into our presentation, I would like to take this opportunity to acknowledge that the land on which I am presenting from, the city of Gatineau, is the traditional unceded territory of the Algonquin Anishinaabe people. I acknowledge the historical oppression of lands, cultures, and the original peoples in what we now know as Canada. We are grateful to have the opportunity to be present in this territory. Briefly, I'd like to go over the Palliative Care ECHO Project. So this is a 5-year national initiative, basically to cultivate communities of practice and establish continuous professional development among healthcare providers across Canada who care for patients with life-limiting illness and their families. I urge all of you, of course, to check out our website at www.echopalliative.com. And the ECHO project is supported by a financial contribution from Health Canada. Briefly, so I'm going to go over the conflict of interest. For Pallium Canada, we are a non-for-profit organization, partially funded, like I mentioned before, by Health Canada. And we also generate funds through the, and operations, of course, through our LEAP course registrations and the sale of our pocketbook. My name is Diana Vince. I will be your host today. I have nothing to disclose, and our presenter, Dr. Carmen Johnson, does not have anything to disclose. So, like I said before, my name is Diana Vince. I am the Palliative Care ECHO Project Manager here at Pallium Canada. I've been with the organization going on 6 years now, and I would like to also present to you Dr. Carmen Johnson. She was awarded by the Dr. Ernest McBrien Award for Family Medicine, the Dr. Murray Stalker Memorial Award, and Dr. Johnson has been serving as a medical director and associate director for the past decade. She is the medical director of palliative services in the RQHR and interim medical director of Sheridan Memorial Hospital and Rural Health Clinic. So a few welcome and reminders. For the comments, I would urge everybody to please use the chat function. So if you'd like to introduce yourselves, say your name, where you're from, or any comments, please use the chat. But for any questions that we will address at the end of the presentation, please use the Q&A, and the questions will be read out loud and answered at the end of the presentation. Remember not to disclose any personal health information during the session. And of course, the session will be recorded, and the recording, along with the slide deck, will be emailed to all registrants within a week or so. So without further ado, I'd like to pass it along to Dr. Carmen Johnson.
Hello, good afternoon. Thanks for coming. We've got a fairly rapid talk going on here. It's just kind of a thumbnail sketch of most things that we can do. I hope it piques your interest, and I hope you're not completely confused by the end. But if you are, there's a Q&A that we can participate in a little bit later. So pain, we're going to take a look at the role of opioids in the management of pain, and we'll also talk about more complex pain management, including methadone and other different adjuvants that we have. And then we'll take a look at some of the interventional procedures that we have available for the treatment of cancer pain. And I have some really great pictures that I've been able to find that should help our understanding quite a bit. So with cancer, let's see, sorry, here we go. Got to get used to this here. Okay, so cancer pain. So the statistics say about 85% of cancer patients will experience pain during their treatment. They say 90% of cancer pain can be managed well. I think we can do better than 90% if we start to identify delirium earlier. But the message is still that most pain can be very well managed. In palliative care, we take a look at the whole person. We have a concept called total pain, and it's a holistic view of the individual as well as how they fit into their family. There are spiritual and physical symptoms that come up. We help mainly with the physical symptoms. Unless though you have the psychosocial needs met or addressed, cultural issues, you usually cannot get the patient completely comfortable. So that's why total pain is so very important. So here are just some of the a list of the opioid analgesics. These are all the immediate release products out there, and some of the brand names. Codeine, I don't use much, but we are familiar with morphine, hydromorphone, oxycodone, buprenorphine, methadone, the fentanyl patches, tapentadol, and tramadol. We also use non-opioid analgesics. Acetaminophen is often used in hospital to try to reduce the amount of opioids needed for pain management. Anti-inflammatory medications also work very well. For specific bone pain, we use bisphosphonates. It's been shown to help retard growth in breast cancer, but also helps a lot with pain management. We're starting to use that in people who have pancreatic cancer as well. The radiopharmaceuticals, this is related to an older product that was called strontium. We don't use it much anymore, but that is there for completeness. Now, if there's bowel obstruction, we can use anticholinergic or sometimes a somatostatin analog, such as octreotide. Other adjuvants include the steroids. We have several choices of antidepressants that we can use. The TCAs are not so popular in this patient population because they're usually a little more frail, but we have lots of other choices available to us. There's alpha-2 adrenergic agonists like clonidine and tazadidine, and more popular are the cannabinoids, either smoked, edible. Some people put it on their skin, and quite a few people I've met are using the rectal suppositories, and that's mainly to reduce the first pass metabolism effect. Now, if you have a compounding pharmacy available, there are many options that you have for the treatment of pain. And they are more than happy to share their recipes with you. So other adjuvants, the anticonvulsants come into play here, the gabapentinoids, carbamazepine. There are some sodium channel blockers. Mixolitine is one I use quite a bit. Some places are doing IV lidocaine infusions, and it's my understanding that they're actually doing them right in the home in BC. And Marcaine or bupivacaine is also used very often with the blocks and ablations that patients can have. GABA agonists also can be used for management in pain management. We use a lot of clonazepam. Baclofen works for spasm. And an interesting class that I'm starting to use more and more is the N-methyl-D aspartate inhibitors, or an NMDA inhibitor. So the granddaddy for that one is ketamine. I'm also using Mantine and amantadine. Other product that would fit in there was dextromethorphan, the stuff that they use as a cough suppressant. Then there are interventional approaches. So there are a whole different variety of groups of injections that our anesthesia friends can provide us. Neural blockade, we will look more at that with some pictures. And basically, you can do a block or an ablation. The block is temporary, the ablation is not permanent, but it's for a longer period of time. Spinal analgesics are commonly used, epidurals, intrathecal. Then the neurosurgical neuromodulation, sometimes they will go in with basically a very hot ultrasound device and destroy a nerve, or sometimes the spinal cord can just be cut. Implant therapies, there's putting in pain pumps, trigger point and joint injections, as well as local anesthesia infiltration are all used. So the psychological approaches are very, very important to help patients deal with the stressors that are happening during this time. Included in that would be your cognitive behavioral therapies, guided imagery, relaxation, hypnotherapy, and also just educational interventions are usually helpful. Once people understand the processes and what is going on, they usually have a lot less stress, and with that, much less pain. Rehabilitative approaches, ultrasound, therapeutic exercise, occupational therapy. We have a lymphedema clinic here in Regina. Hot and cold therapies also seem to be helpful in some cases. The neural stimulation. So the transcutaneous stimulation, that would be like a TENS machine. The TENS machine actually works by shocking the nerve many times until there's no more neurotransmitters to go across the nerve cleft to transmit signals anymore. Transcranial is also used. There are several different products out there that the one that I've been using is one that has, you have ear clips and the tiny microcurrent will go back and forth across the brainstem, and that seems to downregulate pain, and it helps a lot with sleep, anxiety, as well as pain. Then there are the implanted therapies, the stimulators. Sometimes it's right at the dorsal root, but sometimes they will go just put them in the periphery. And of course, things aren't complete unless you have some of the complementary and integrative approaches, acupuncture, massage, physical movement, music therapy, and art therapy. We're very fortunate to have a music therapist in our program here. So a little bit more depth into the opioids for cancer pain. So I don't use codeine very much. It is a pre-drug. It has to be converted to morphine to work. And in our population, about 15% of people do not have a robust enzyme or lack the enzyme completely to do this conversion. And then if people are on any antidepressant medication, such as SSRIs, this enzyme is blocked. So if you're giving them Tylenol with codeine, they're only going to get the Tylenol effect. They still might get the new effect of severe constipation, but they don't get the analgesia effect of the morphine, or when codeine converts to morphine. So morphine we're quite familiar with. It is a binder with all the three opioid receptors, the mu, kappa, as well as delta. So is hydromorphone, oxycodone, buprenorphine. Suboxone has buprenorphine and some naloxone in it. A lot of people think that the naloxone will block any other opioid receptors. It does nothing for that. Basically, the naloxone is in there just to reduce the risk of injection, because it'll block the uptake of the buprenorphine if it's injected with it. But if it's taken by a sublingual route, that does not happen because the naloxone is destroyed in the gut. Methadone is one of our favorite favorites around here. Fentanyl patches are quite useful and are the treatment of choice in some areas. We don't use them much because there are a lot of different caveats with them. You can't titrate them quickly, and our patients, sometimes they don't have enough fat tissue to absorb them. So that's just our preference here, but certainly there's nothing wrong with using them. The other two, tapentadol, it's a mu agonist. It has some norepinephrine reuptake inhibition. And then tramadol, it is a weak mu agonist with serotonin and norepinephrine uptake. I don't use the last two very much. First of all, they're not covered. And I also haven't seen the results I want using them in pain, cancer pain especially. So we'll just talk a little bit about methadone. There are a lot of myths out there about methadone. So methadone is a very old drug. It was developed in 1937 by the Germans as a long-acting analgesic. And it always has been a long-acting analgesic. The concerns are that it doesn't work for 3 days. Well, that doesn't make any sense, because if I give you your amoxicillin, am I going to tell you that that's not going to work until you've had at least 5 doses to get at a steady state? No, that's not the way it works. So methadone will start to provide analgesia at about 30 minutes. Its peak effect for that specific dose is around 3 hours. The patient might get some analgesia, maybe 4 to 8 hours with the first few doses, but we use immediate release hydromorphone or morphine in between to make sure that the patient is comfortable all the time. As we continue to use the methadone, the duration of analgesia will increase as the methadone gets up to a steady state. Another myth is out there that you can't use methadone on opiate-naive patients. You certainly can. You can use them on opiate-naive patients, people who don't tolerate other opioids. You can get very, very low doses of morphine equivalents. If you get from the 0.5 milligram of methadone, that's 5 morphine equivalents for 24 hours. Usually we're using methadone 0.5 twice a day for dyspnea. The 10 morphine equivalents seems to be the lowest dose that is helpful for dyspnea. And we have very good success with that. So if you're starting somebody opiate naive on methadone for pain, usually we'll start at 0.5 Q8 and titrate it from there. If we do conversions, the dosages start a little higher, but that's a whole other talk. Another concern is, oh, you can't use it in liver failure because it's metabolized in the liver. Well, all drugs are metabolized in the liver. And basically, we just use the knowledge that's been given us since we started to have pharmacology in medical school. You just start low and you go slow and you see how the patient responds. Methadone causes QTC prolongation. Yes, it does. And many medications cause QTC prolongation. And methadone doesn't seem to cause that unless it's at higher doses. Now, the definition of a higher dose has changed a lot over the last years. It used to be 200. Now they're starting to check an ECG around 60 to 80 milligrams daily in our clinics here in town. There are a lot of potential cytochrome P450 interactions and drug interactions, and that is true. But how many of them are clinically relevant? If you keep your eye on the patient and see how the patient is doing, that is what is important. And there actually is no known incidence of QTC prolongation with methadone. If you have a concern, get an ECG, take a look at it and see where things are. So methadone, you can basically most routes, PO, buccal, PEG, rectal, topical. You have different sizes of tablets and different strengths of commercial liquids. If you want a higher concentration, let's say you're giving a higher dose to a patient who's not swallowing any more, you might want a 50 milligram per mil or 100 milligram per mil solution so that the volume that you're putting in the cheek is not large. That's basically how we've been doing it. We used to try to give it rectally, but again, that takes a lot more work, and the buccal works quite well with these higher concentrations. If you want to use it topically, you have to have a compounding pharmacy. They mix it in some lipiderm, and they'll usually add a lot of other analgesics. You can use it on a wound that you don't want to get wet. You can use stomaadhesive powder and mix it with methadone and then sprinkle it on. We've had some good success with that. You do have to pick your wounds carefully. It has to have a blood supply, and it doesn't work on a dry eschar. So metabolism and excretion. The great thing about methadone is there are no neurotoxic metabolites. It is metabolized in the liver to completely inactive metabolites. Normally, excretion is 50-50 through the urine or the feces, but in renal failure, you don't have to worry about an adjustment. It'll go 100% out the feces, and it actually is the analgesic of choice for those on dialysis. Buprenorphine, the Butrans patch is an interesting product on the market. Unfortunately, it's not on the Saskatchewan formulary. I do use Suboxone, which has buprenorphine and naloxone in it. I've had some very good results, and I have used it in cancer pain as well. There's a myth about Suboxone, though, that the buprenorphine will bind and not let any of the other opioids work. Certainly, it depends on the saturation of the buprenorphine. Hydromorphone has a pretty close affinity compared to Suboxone. The only one that has a higher affinity is fentanyl. So you do have some choices for breakthrough analgesia if you need it, or you can just use more Suboxone. Ketamine. Ketamine is really great with neuropathic pain. Often if a person's in a pain crisis and they have a lot of tolerance to the opioids, we can bring their pain into pretty good control fairly quickly. Some places use IV infusions. We don't have that available here. We will give intermittent boluses in some of the chronic pain clinics in town. And usually here on the palliative care unit, we're using it orally and sometimes sub-Q. Ketamine is an analgesic on its own, and it has a metabolite that's even a stronger analgesic than ketamine. We use this to help reset the opioid receptor sensitivity through a complete blockade of the NMDA receptor. Usually, if we're resetting somebody's receptors, it takes about 5 to 7 days of treatment with ketamine. I have used it long-term in some patients that have needed it, and you just watch out for bladder irritation. It can cause some ulcers and bleeding in the bladder. So Mantine is a very interesting old drug. It is marketed for Alzheimer's disease. It's a partial antagonist at the NMDA receptor, and it slows down the firing of that receptor. Certainly, I'm seeing benefits in fibromyalgia and chronic pain patients with this drug class, and especially with my complex regional pain syndrome patients. It is very interesting. There has been one study of Mantine at 60 milligrams a day, which is, I think it's 3 times the recommended dose for Alzheimer's. But they did a whole bunch of brain imaging throughout the study, and they could see the one part of the brain starting to return to normal. they're actually able to cure these people of their complex regional pain syndrome. So there's lots of opportunity to look at those drugs there. Lidocaine, again, they're doing it in the homes in BC. It's a very low risk procedure. We don't do it in our hospital. Once it gets to the hospital, there are a lot of different regulations that have to be met, and they usually get in the way. Here we can only do that in the ICU. And of course, we don't have our palliative care patients there. Sometimes the lidocaine infusion will give lasting relief, just an intermittent infusion for days to weeks. Here in Saskatchewan, we don't have those resources, so I use Mixolitine. So Mixolitine is a class 1B antiarrhythmic drug. It works on the sodium channels, and when you take it by mouth, it converts into a molecule with a similar structure to lidocaine. The dose for rhythm control is 400 a day, the least dose, but I'm getting some good results, 100 milligrams twice a day or 100 milligrams 3 times a day. I have titrated a few people up. I recommend that they sit up for a half hour after taking it. The problem with Mixolitine in most of the studies is that it's not tolerated well by the GI system, and people have had to quit using it. Then plexus ablations and blocks. So we'll take a look at these different ganglions where we can put anesthetic agents. The stellate ganglion, that will give analgesia to head, neck, upper arm, and upper chest. Cervical plexus, you can get surgical analgesia for the arm I'm sorry, not the arm, but the neck region. Brachial plexus, you can get relief to the arm and shoulder. Celiac plexus, that controls a lot of different innervations from the liver, gallbladder, down to the omentum, and the first 2/3 of the large bowel. And if I block that, I often will get pain relief, but also nausea relief. So there are also a couple other ones that I haven't seen much. Superior hypogastric plexus, that's for pelvic pain. There's also the inferior hypogastric plexus, which helps in pelvic pain. We do ask for the ganglion impar block fairly frequently. It's very helpful in people who have lesions in the perineum, vulvar cancer, squamous cell carcinoma of the penis, and perhaps even radiation burns and such. Now, just a few definitions here. A block is temporary. So bupivacaine is a long-acting sodium channel blocker, and that will last about 72 hours. And this is a product that a lot of the surgeons will put in around the incisions as they're closing up after surgery. So the patient has good analgesia after surgery. And sometimes they will do a block just to see if the anatomy is in a place where they can get some efficiency before they go in and try to do the ablation. So ablation is longer acting. Radio frequency, that's the heat with an ultrasound. And then we can also lyse the nerve plexus. Basically, here in Regina, they're using absolute alcohol. You can also use phenol. And what it does is basically just melt the nerve plexus. The nerve will regenerate if needed. These ablations can be repeated every 2 to 3 months. So here's a cool picture. This is where the stellate ganglion sits. And again, it helps with nerve pain into the head, neck, upper arm, the upper chest as well. And it comes from a fusion of the inferior cervical and superior thoracic sympathetic ganglia. So it's a popular block to do. Celiac plexus block you can see needles kind of pointing in 3 directions here to get a good dose into the area, and it will help with nerve pain in the neck, on the side of the neck, the ear, the clavicle, the acromioclavicular joint, and it's innervated by C1 through C4. Brachial plexus block is just a little further down, and I haven't seen it done very often. I imagine they're doing it with ultrasound guidance. If you have an interventional radiologist or an interventional pain anesthesia physician, it will give anesthesia to the upper limb, and it comes from the shoulders down to the fingertips, and it has C5 to T1 innervation. So that can be quite handy. Now, these are the ones that we don't see a lot. And this diagram on the right has the word superior hypogastric plexus. So there is a superior one, and then below there, not described here in this picture, is the hypogastric plexus. And so they're both very close together, and they will help provide relief in the pelvic area. Also, it helps in the colon, the bladder, lower intestines. It'll provide analgesia in the uterus, ovaries, as well as the prostate. So the celiac plexus, there are a couple different approaches that they can do for the celiac plexus. So our GI guys can come down and basically go through the stomach wall. You can see the endoscopic device on the right. The needle is pointing towards the left. And then on the other side of the gastric wall, there is the ganglion, which is the celiac plexus. So apparently, or at least the GI guys say they're better than the interventional radiologists. I'm not exactly sure if that's really true, but it is a different approach. And sometimes if you can't get the celiac plexus blocked, either from the internal method, you can go to an external method, and vice versa. So here is the interventional radiologists of most of the approaches around here. You have the celiac plexus described by this white area here. You have the vertebrae of the backbone, and in front of that, there is the big aorta. So you really want to know that you're in the right spot. This is a CT guided intervention. And sometimes the anatomy will allow for a good block or ablation. Sometimes not, but we usually have more success than we have failures. And the patients can often get off of their analgesics completely, which is helpful for everybody, and their pain's well controlled, and they can have a good quality of life. This one I haven't seen. So this one looks like it goes right through the liver into the ganglion or the celiac plexus area. And that, of course, would be done under ultrasound guidance. We don't do that here in our area, but this diagram's here for completeness. So again, with the celiac plexus block, we can block nerve pain from the liver and gallbladder, excuse me, the stomach, pancreas, splenomentum, both kidneys, the entire small bowel, and the first 2/3 of the large bowel. So the ganglion impar. So ganglion impar is an interesting plexus to block. It was first described in 1990 as a method of providing analgesia. So there are 3 different positions that you can be in for the procedure. You could be on your back, on your side, or laying on your, laying on your back, laying on your side, and sometimes laying with the needle coming just anterior to the coccyx. So you would also be on your back for that one as well. It is the very last ganglion of the sympathetic chain in the body, and it sits right in front of the tailbone. And it innervates the vulva, the distal rectum, the anus, distal urethra, and the distal third of the vagina. So if you go back to your embryology, the third of the vagina is from one tissue type, whereas the other 2/3 of the vagina is another tissue type. So that's how we can get some analgesia in that area. It works quite well. So this is the lateral approach. Sometimes people are laying on their sides with this. Now you see this line here, that's the needle coming in. Again, it's CT guided. You can see the coccyx or the tailbone just above where the needle is coming through. And that would be where the ganglion is located. So this is the lithotomy position. It is sometimes how they will put the patient to go through the perineum and just into the ganglion from that direction. I'm sorry, I couldn't get you a good picture of that, but the patient is laying on their back and the needle is just brought in behind the rectum and then back in towards the coccyx and then gets to the ganglion plexus. So this one I haven't seen done here, but it looks like they're using ultrasound and they're going through the different sides of the coccyx. The coccyx bone is quite small, and there is sometimes a lot of room to be able to maneuver in that area. Again, this is with ultrasound guidance. So epidural analgesia, so they can put opioids or other local anesthetics into that epidural space. You can do a bolus injection or a continuous infusion, or sometimes the patient can control how much drug they're getting. It can be long-term or short-term therapy, and it can be used in all age groups. The catheter tip is close to the spinal nerve, so you can use it for any specific dermatome in the body. So the dermatome is supplied by a specific spinal nerve, and so that's how you'll get the analgesia at that point. Now, for epidural anesthesia, so analgesia, epidural analgesia, that's just taking away pain. Epidural analgesia is basically they can't feel anything, and basically they just use higher doses, and there'll be a complete loss of sensation as well as motor function until the block or the epidural is discontinued. Spinal anesthesia, so there are a lot of different names that can be confusing. They all mean the same thing. Spinal block, subarachnoid block, intradural block, intrathecal block. And basically local anesthetic or opioid is put into the subarachnoid space. So here's a picture of where the epidural space is, and then underneath the dura. So there's there's the vertebrae on the left, and then as you go in, there's this blue area that bathes the spinal cord. That's in the intrathecal space. And then on the right, you'll see epidural, and the needle goes into a kind of a pinkish orange area above the intrathecal space. So that's the difference in position for those. So what are the advantages or disadvantages? Well, if you do a spinal or an intrathecal, You can only do it in the lumbar area because you don't want to paralyze the diaphragm. The duration of the block is fairly brief, but it's good for different procedures. Sometimes it's used for gynecological repairs or even knee surgeries. It gives a good block. The epidural you can use anywhere. So if you have pain in a certain area of the body, you can locate whatever spinal root innervates that area and go for it. It isn't as good as a quality block as a spinal, but the advantages is that you can use it in longer procedures. Disadvantages with the spinal, increased risk of hypotension. So if you knock out the parasympathetic and sympathetic control of the blood vessels, you get quite a vasodilatation, and you can get into hypotension. And there's always the risk of a dural puncture headache after the procedure is done, usually treated with a blood patch if identified early enough. The advantages of the spinal, you have a segmental block, greater control over the analgesia, and possibly long-term analgesia as well. I'm sorry, that is for the epidural, not for the spinal. You can get some profound muscular blockade with these duraxial anesthesias. So it's pretty cool stuff. I have some resources here. I guess we probably have some.
We do. We have a few questions, yes. So I wanted to read out a couple of the questions for you, Dr. Johnson. The first one is, what kind of pain would you use sodium channel blockers for?
So sodium channel blockers, basically, it's for nerve pain. I use it sometimes in conjunction with gabapentinoids. They do seem to be synergistic in that they will work well together. The gabapentinoids do have some effect on the sodium channels, but it must be a different pathway because they are synergistic. So I use it for nerve pain.
Fantastic. And then for Mary, we have you ever experienced respiratory depression with ketamine?
Not here. The ketamine bioavailability, we usually use it orally here. So the ketamine bioavailability is quite low, and we're usually using it for resetting the receptors. Now, if you're not cautious with reducing the amount of opioids, as you're resensitizing those receptors, you could get into some respiratory depression, but we watch that fairly closely.
Okay. From Stephanie Young, we have, for opioid naive patients that you are starting on 0.5 milligram methadone Q8 hours, what are you suggesting for a PRN dose? Typically 10% total daily dose, but that would be tricky with only having 1 milligram tab unless you use liquid for PRNs.
Yeah, so if you're using methadone PRN at higher doses, I just use a 10%. Now, if we're down at the 0.5 doses or 1 milligram doses, the dose is so low that let's say if I have somebody on methadone a milligram 3 times a day, and I can only use methadone as a breakthrough, I'll go half a milligram of methadone. And certainly that's not the math that they teach us, but it is the practical thing to do. And it also seems to be quite safe.
Okay. For Mary, we have, do you sometimes use epidural steroid injection for analgesia, sorry?
That goes through our anesthesiologist friends. It's usually used more in chronic pain than cancer pain, but there's nothing saying that it could not be done.
Okay. Stephanie Young, we have for us in rural Saskatchewan, what would be the best way for us to gain access to neuro blocks for our palliative patients that wish to consider these, but not be transitioned to permanent care in the urban centers?
I'm not sure if it can be done. Usually, what I would recommend is if you're getting to a point where you're thinking that an interventional procedure is the only way to go, your opiates are going higher doses, perhaps think about resetting them. And we rarely have intrathecals or intrathecals or epidurals here on our unit. I think we've had one or two, and I've been here, I guess, 15 years now, and we've been able to manage pain in other ways. If you're out there in rural Saskatchewan, we do have the link line. I'm usually the one that answers the phone during the work week. It's available 24 hours a day, 7 days a week, and we can certainly walk you through that. But yeah, the problem with these more interventional things, you have to be in a larger center.
Okay. Thank you very much for this insightful presentation. Can you talk a bit more about your use of transcranial stimulation?
Okay, so the transcranial stimulation is more for a chronic pain. I don't really want to say what kind or advertise things, but the microcurrent stimulator I've been using for a long time is an alpha stim, and there is a dealer in Calgary. You can look it up under Natural Pain Products .ca, I think, or else you can Google Alpha Stim Calgary, and it'll take you to the website. The mother company, the website there is www.alpha-stim.com. It has a lot more information, and there are a lot of different ways that these products can be used, and it's mainly for chronic pain. I have used it on some cancer pain patients, but usually it's because they're having some myofascial pain and muscle tightness and stiffness, and that's helped provide them relief for that.
Yeah, thank you. From Eve Jonas, we have maybe a very basic question, but what are MU and kappa delta?
Those are the 3 opioid receptor names. So the mu was the first one, and then delta is the second one, and kappa, I have no idea how they named them, but that is what they are called.
Okay. From Lisa Gingras, we have in Manitoba, a specialized physician has to prescribe methadone for harm reduction purposes. Is this applicable to palliation as well?
No, here in Saskatchewan, we can prescribe methadone for pain. Any doctor who can prescribe controlled substances can prescribe methadone for pain. For harm reduction, though, they need the specific exemption from the College of Physicians and Surgeons.
Okay. From Chita Agonoy, we have, if a patient experiences hypo BP, what do you usually do?
Well, usually, they're laying down as we start these things. If the blood pressure is too low, we will often stop the therapy for a while. But again, remember, here we don't use infusions. We're not using continual opioid infusions. We're just using intermittent dosing for analgesia. The studies have shown that intermittent administration of analgesia is just as good as the infusions, and it seems to be less invasive for the patient and family. So that's what we do. If we're concerned that this person might have some low blood pressure, we will give them IV fluids, but it's so very rare, and it really hasn't happened.
Okay. From Leah Puntanen, I'm seeing more patients coming home on Suboxone. What is the ceiling dose that you would recommend to manage pain at end of life? If Suboxone not managing pain, when might you consider adding an opioid? So it's really 3 questions.
Yeah. So Suboxone, we're just starting to learn how to use it for pain. It was manufactured initially in 1985 as a long-acting analgesic, and similar to methadone, they found that it worked well for the treatment of substance use disorder. So that's where most of the information comes from. Now, for a substance use disorder, they're looking at 24, 32, sometimes maybe 40 milligrams of Suboxone a day. There is confusion about this thing called a ceiling effect. So the people think that the ceiling effect applies to analgesia. It does not apply to analgesia. It applies to respiratory depression. So it's kind of a poor wording of the concept. Basically, you can only suppress the respirations to a certain point, and then they won't go down any further with Suboxone. But I am still learning how to use it for cancer pain. I have used Suboxone as a PRN. If the Suboxone isn't working, often you're using other adjuncts before you're going to your opioids anyway. And if you are going to use a PRN, again, you can use the Suboxone as a PRN. Hydromorphone works as a PRN, especially if you're, in the doses around maybe 24 to 32, that people will still get some analgesia from hydromorphone. The affinity for hydromorphone and Suboxone for the mu receptor is very close. If you do need to possibly use something else, fentanyl subcutaneously or bucally or sufentanil bucally could also be used.
Okay. And then we have from Paul McIntyre, he's saying there is a strong recommendation against the use of Mixolitine in neuropathic pain. He says he put the reference of where this comes from, and he has not used Mixolitine since the 1980s. So I think this was simply a remark.
Yeah. But it certainly does work. And I'm not sure. I've talked to the cardiologist to see what the concern might be, and even with some of the more rare types of arrhythmias, Mixolitine seems to be quite safe. It's interesting that's first I've heard that there's something saying not to use it. But I think the problem is that they were using higher doses, and most of the patients didn't tolerate it because of GI side effects. So that might be where that opinion is. As far as I know, I don't know what the danger would be, and I've checked it out with our colleague cardiologists here.
Okay. Do you have, this is another question regarding the same drug, do you have an algorithm treatment dosing regimen for Mixolitine that you could share?
No, not really. Usually what I'll do is I'll start it at 100 milligrams twice a day, see if they tolerate it, see if they have any benefit from it. If they do have some benefit from it and tolerate it, I might take it up to 400 milligrams total a day. I have one fellow who is on the max recommended dose for arrhythmia, but his case is so very extraordinary. He's the only one that I actually have on a what they call a therapeutic level or therapeutic dose of the Mixolitine.
Okay. And then I'll wrap it up with this one, the last question. What do I need to consider when starting methadone for someone who is already taking hydromorphone? It makes sense sometimes to continue both, correct? Do you use a higher starting dose of methadone because the patient is already used to hydromorphone?
That's an interesting question. The higher the dose of other opioids that they're on initially, the lower the dose is for your methadone to start at. There are quite a few different conversion tables out there. We're a small center, so we don't have any specific name for ours, and we're not in any studies, but I took the 2008 methadone conversion table from Fraser Health and worked with it for a while, and noticed that maybe it was a little bit too generous on the low end. Adjusted some of the conversions a bit, and then I took out the incomplete cross tolerance conversion, because that is usually what people forget to do. And basically, as the morphine equivalence goes up, the ratio also goes up. So if you get over 30 milligrams as the answer to your conversion, check again.
Yeah.
I usually won't go above 30 milligrams.
Fantastic. I'd like to thank everybody for attending today for this session. Thank you so much, Dr. Johnson. Once again, a very informative session regarding pain management and palliative care. And have a lovely rest of your day. Thank you so much.
Thank you.